So we all know that visualization is the key for any posterior segment surgery, and there has been revolution uh, for in past 1 or 2 decades regarding the equipment and wide field viewing systems. But they all depend on the clear ocular media, and we must remember that if there is any problem in the ocular media, which may be in terms of visualization through cornea or in the anterior chamber or in the lens. Now, most of the times we do encounter the lens pathologies, but we are habitual to tackling lens opacities easily, which we can do now. But the cornea remains the issue because availability of the corneal tissue is a problem in majority of the setups. Temporary K-Pro is one of the methods to tackle that, but then again it poses a problem because you need a graft immediately after the completion of the surgery, which may again not be available in all the centers. Certain anterior chamber pathologies like pupillary membranes, etc., may again pose a problem, and in these cases, we may resort to alternative visualization methods. Now, endoscopic visualization is one such method where we bypass the ocular media and we can directly look at the structures behind the iris. Indications, as is obvious, would include the media opacity, especially the corneal condition, uh, especially the corneal conditions which are not easy to tackle, and a retinal condition which requires quick intervention. For example, endophthalmitis or retinal detachment would be on the high priority list. The reason being, we may tackle the cornea with a graft, but by that time the retinal condition may progress and lead to poor visual outcome. So conditions like endophthalmitis, where there is involvement of the cornea, there is extensive involvement of the AC with pupillary membrane and exudates, one may resort to endoscopy method to tackle the posterior segment. Conditions like already where the keratoprosthesis has been done, the visualization may not be great through that, and we may again have to resort to endoscopic methods. Next would be something like when the location of the lesion is in the a place where we cannot see with the help of conventional visualization, even with the help of a wide angle visualization system. For example, the retroiridial area or the anterior PVR, where we can not easily see with the wide angle visualization system. One haptic of the SFIL has dislodged and we need to refix it. So these are the some of the scenarios where the visualization is not good with the conventional visualization system, and one may have to resort to endoscopic visualization. Not again important from the uh, retinal perspective, but endocyclophotocoagulation, whenever required, may be done with the help of endoscopic system. Now coming to setup, it is simple setup. This is the system we have at RP Center. It is E2 system, endoscopic and laser system. Many versions of this system are available, the latest being E4 endoscopic system. The system basically consists of a console which has a probe, which is a single probe, which has ports for lighting, the camera, and the laser. Now, whole of this console is attached to this monitor, which displays the image from the camera. Now, it is very easy to understand nowadays with the onset of what we have digitally assisted vitreoretinal systems. What we have here is, rather than looking into the microscope, we look at the screen, and whatever is captured by the camera through the probe is projected onto the screen, and we have to look directly at the screen and not into the microscope. So if we are doing a diagnostic procedure, then just this bit of system, endoscopic system is required. We put a probe over here that goes inside the eye, and we look at the monitor to see what is happening inside the eye. But if you are planning a simultaneous intervention, then vitrectomy setup along with this system would also be required to tackle the pathology at the posterior segment. So this, as I mentioned, is the housing console, where you have a xenon light, which is attached to the probe over here. Then you have a diode laser, which is the laser aperture, which can provide laser light of sufficient intensity and duration. And we have a camera system which processes the image and which is perceived from the endoprobe and goes into the monitor at the top. Now we have various endoprobes of different gauges available. It can be 19 gauge, 20 gauge, or 23 gauge. The field which is provided is maximum in the wider bore in the 19 gauge, while it is the minimum in 23 gauge. And also the number of pixels is higher with the wider bore uh, gauges. Now 20 gauge is the most commonly used, as it gives adequate visualization, as well as we don't have to enlarge the port. Usually I use the MIVS cannula when I'm using 23 gauge port, and I think wider is the bore, it is easier for the uh, beginners to do the endoscopy. Now, before I go into my video, just a simple step before we go inside the eye. There is a system on the probe where you can rotate the image. So before we enter the eye, we always check that the 12 o'clock, what is the 12 o'clock in the probe. And then once we go inside the eye, we go closer to the structures until the structure is visible. So in this particular case, this patient had a pro, with had a bullous keratopathy, aphakic bullous keratopathy, and on ultrasound we could see that the lens has dislocated, but the projection of rays was inaccurate. So before taking up the patient, we wanted to know whether we should proceed with the surgery. So we did a diagnostic endoscopy for this patient, and once we go behind, we see that there is a mature cataract which is there. We can see some retinal vessel. Disc is yet not visible. We go closer to the lens, and once we displace the lens bit toward the side, we can see, look at the disc. So disc is visible, which seems pale. All the vessels looks closed. So this is one of the patient which is not going to get much help with the intervention. So basically, this is how the setup looks like. Uh, Indications I have already summarized. There are not many contraindications, but this is one procedure which has a long learning curve because there is no stereopsis. So one has to be really careful and go slow in the beginning because there are high chances of touching the retina and the ocular structures. But endoscopy has a definitive role in selective cases. It may be diagnostic or therapeutic. Thank you very much.